We have now entered the thoracic cavity. And the thoracic cavity, it consists of three separate cavities. What do I mean by that? Well, there's going to be a pleural cavity of the left lung, a pleural cavity of the right lung, and a pericardial space for where the heart resides. Where are these cavities? Let me just show you the pleural cavity first, before in the next video we will then enter the pericardial space. Pleural cavity lies between the parietal pleura, which we tore when we were removing the rib cage. Here's parietal pleura. It is called parietal because it is the membrane against the body cavity. And this would be, you would separate it away from the tissue or the lung, and then residing microscopically on the lung tissue itself would be the visceral pleura. We cannot see it, but it's there. Consequently, the pleural cavity lies between the visceral pleura and the parietal pleura. And we tend to say that it's a potential space. That is, it's not a real space until there's pathology associated with it. For example, a pneumothorax, where air gets in between the visceral and the parietal pleura. Normally there's only a small amount of fluid, and that fluid is there to help ease the gliding of the visceral and the parietal pleura when we inspire. We know that on the left side and on the right side it is separated from the pericardial space, and now we see this pericardial membrane. It is not surrounded by pleura whatsoever, and consequently we call this the bare area of the pericardium. And it's clinically relevant because if you ever have to enter the pericardial space, you can enter through the bare area of the pericardium without having to injure the parietal or the pleural cavity. At this point, we need to examine or find the phrenic nerve. The phrenic nerve starts in the neck and travels down into the thorax, where it then proceeds onto the diaphragm, and this is the nerve that innervates the diaphragm. It originates from C3, C4, and C5, spinal nerve C3, C4, and C5, and the mnemonic to remember is C3, C4, C5 keeps the diaphragm alive. To find the phrenic nerve, which resides in the thoracic cavity outside the pleural cavity and the pericardial cavity, we need to reflect the left lung away from the pericardial cavity, and now we're in the thoracic cavity but outside pleural and pericardial cavity. And to find the nerve is very straightforward. We just put our finger in there and the nerve literally just pops out. It is this nerve right in here. And basically it would just travel all the way down to the diaphragm. And now look at this super enlarged heart that has occupied so much of the thoracic cavity. Nevertheless, the phrenic nerve is traveling outside of it, and I can continue just using my fingers to separate out the nerve. All the way to the diaphragm, like so. And accompanying the nerve is what we call the pericardiaco-phrenic artery and vein. And this is a small vessel, but you can actually see, and it travels all the way from the neck to the diaphragm. To find the right phrenic nerve, we repeat the procedure. We reflect the right lung, we move the pericardial cavity to the left, we put our finger in to that space, pull out fat, tissue, and sure enough, there is the string-like phrenic nerve, very easy to feel and identify. Our next goal is to remove the lungs. And the reason we do this is because it is very difficult to remove the heart, which is a final goal of this dissection, without first removing the lungs. The space is not big enough to put our hands in here. Everything's embalmed, everything's fixed to one another. So our first strategy is to remove the left lung and then the right lung. To do this, we have to go into the pleural cavity, and now you know where that pleural cavity is. We have reflected the parietal membrane out of the way, and once we're in the pleural cavity, we start peeling off the parietal pleura as far away from the lung as possible until we find the root of the lung. And the root of the lung is where all the business parts of the lung enter. Now what I'm looking at here is the upper lobe of the lung. The inferior lobe of the left lung is actually posterior, and it's hard to see at this point, but we'll see it once we take the lung out. So the root of the lung is approximately at this area, that area that I'm pointing to now. I'm going to focus on that area and zoom in. And the strategy now is to basically create a space around the root of the lung, and we will cut through everything in the root of the lung. That is the primary bronchi. We'll cut through the bronchial arteries, bronchial veins, nerves, lymphatics, basically any tissue that goes and enters the lung at this point. So with my scalpel, I will cut as close to the midline as I can get and cut through all the tissues in here. And now I will zoom back out, and basically I'm going to put my hands and separate the lung tissue from the ribs. And you have to be careful because remember, we cut the ribs and the ribs are sharp. And basically I'm just going to rim the lung all the way around. And this was a left lung that you can see now. So you can actually see the primary bronchus there, the pulmonary artery, pulmonary veins, and different impressions from the different tissues. The heart impression is right here, and you can see the much larger upper lobe and the left inferior lobe right here. I will now move and do the same thing with the right lung. Let's see if it comes out a little bit easier. Now the right lung has a superior lobe, and it's separated by the horizontal fissure from the transverse lobe, and it also has an oblique fissure separating the inferior lobe down here. And now what I plan to do is go in here, again identify the hilum of the lung. I'm going to cut through as we did before. And now let's see if the lung comes out much easier. There we go. And again, we can now see this is a very large, well-embalmed lung. And again, you can see the primary bronchus. I can actually identify the cartilage right there in the bronchi, as opposed to artery and vein.